wanted to kind of talk about what have we learned from over the past 30 years with advanced heart failure. You know, the days of diuretics, digoxin, and oxygen, now to a plethora of different medications we can use, and a lot more we know about pathophysiology that we've learned. So, next slide, please. I have no disclosures. So, objectives. We're going to discuss the epidemiology. So, this could be a two-part series, and today we'll talk about the first half. We'll spend about 35 minutes on the slides, and then we'll go over a case study, and then we'll do a part two at another time. I do that in August. I think like August, sometimes I think like August 16th or whatever that is. But sometime in August, I'll be getting part two. Yep. So we're going to discuss the epidemiology of heart failure, kind of the staging system we've used, which is kind of relatively newer in the past 10 years or so. We're going to discuss the evaluation of patients, what medications we utilize, the triggers for advanced heart failure referral, and kind of a I need help acronym, which is very helpful in knowing which patients to refer. Next slide. Really, you know, heart failure is kind of what we see is really we only see the tip of the glacier. So really heart failure encompasses a lot of patients. But, you know, really the patients that we see are only really kind of the advanced symptomatic. There's a lot of different patients with heart failure that they don't know about, and so we really underestimate the disease burden. In fact, next, and it's obviously more heart failure that we can see with this. Next, the epidemiology, the lifetime risk of developing heart failure is about 20% for Americans greater than 40 years of age, and 30-day post-admission mortality was 10.8% in 2005. That's improved, but still significant mortality even back then. Heart failure is a primary diagnosis in over 1 million hospitalizations annually. There's a 1 month readmission rate on average about 25%, and that's where when you look at the Medicare criteria of getting kind of dinged on heart failure readmission, 25% is kind of the benchmarker for that. It costs a lot of more. It costs not only it's a lot of morbidity and mortality to the patient. It's very costly to the system. In 2010, physician office visits accounted for almost $2 billion of heart failure costs, and the total cost of heart failure care in the United States exceeds $40 billion annually, and over half of that is spent on hospitalizations. And so, really, a smaller number dealing with the inpatient side. Really, what we have to do a better job of is tuning these patients up and keep them outside the hospital, which is, I think, really important in managing these patients. Avoid them to getting into the hospital, because once that happens, a lot more morbidity, mortality, and costs occurs. Next slide. You know, and it's only getting bigger and bigger. So this is, you have the baby boomers, they're aging. So here's kind of a projection of what heart failure patients are going to look like by the year 2030. And you can see really your Medicare population, which is their 65 to 79-year-old and even greater than 80, you almost see doubling of that population from 2012 to 2030. And that's the aging of the baby boomers. So we think heart failure costs are expensive now. It's gonna really explode in terms of cost. So I don't think we're ready yet to deal with that. I think we're trying our best. But as you can see by this slide, the population's booming. So we're gonna have a lot more morbidity and costs associated with heart failure. Next slide. And we got to really define the patient populations, and that's where past 15 years or so, in the old days, we just had kind of New York Heart Association class, and their symptoms would bounce around on the timeline where they get admitted to the hospital, they're class 4, they're diuresed, they're class 2, and that really didn't tell us a progression of how their disease is doing. And we really need to do that, and defining the patient population, we're doing that. So now we use more of a staging system in conjunction with functional status and, you know, A, B, C, and D. And really, as you can see by the slide, primary care providers play a big role in helping these patients out. You know, stage A, they have hypertension, but no abnormal echo or any kind of cardiac symptoms. Those patients need ACE inhibitors, beta blockers, whatnot, depending on what their makeup is. So it's very important to be very aggressive with medications that put them at risk of developing heart failure. As time goes on, those patients then can have asymptomatic LV dysfunction. Say they got an echo for chest pain, and in fact it was just a insulodentaloma where they found out their EF was now 30%. So that plays a role as well. So really, using meds are very important. And primary care is very important, but cardiology starts playing a role. They start getting referred for asymptomatic LV dysfunction. But as you can see on this spectrum, primary care providers from A to D play a role in this. And as they develop symptomatic heart failure, cardiology plays more of a role in terms of its management, but primary care providers are sentinel in managing and helping these patients out. And then you have where advanced heart failure becomes more of a prominent role when these patients reach stage D. So these stage D patients are the ones that are very advanced, and really primary cardiology plays less of a role, and advanced heart failure cardiology plays a prominent role. So as you can see, A, B, C, and D, and you can see it's a progressive disease this way. It doesn't bounce around back and forth like a New York Heart Association class. So very, one direction, A, B, C to D. So, this is, just like hypertension, diabetes, they will always have heart failure. That doesn't go away. Next slide. So if you look at the scope and burden of the heart failure in the United States, that's why primary care is so important. Of this large population, you're talking 100 million people, 94 million or 94% of them are really, risk factors or asymptomatic LV dysfunction. So really, primary care providers play a sentinel role and help prevent progression in the disease. So always, as we go down the road, stage D, 200,000, that's really the zebras. The majority are people with heart failure with symptoms that can be diuresed and tuned up, or the people just have risk factors. So really, as I mentioned before, primary care providers play a sentinel role in this. Next slide. And if you look at it, the prevalence of asymptomatic LV dysfunction is about 3 to 6% of the population. And as you can see by the slide, normalization, having a normal LV function and doing well, you live longer. I mean, that's kind of the rule of thumb. As the LV dysfunction progresses, survival gets worse. So it's always very important to make sure we treat these patients appropriately. Next slide. So if you look at the mortality of heart failure, it's approximately 300 deaths per year. Next. And if you look at it, once they're hospitalized, the mortality kind of goes through the roof. So if you look at patients that have been hospitalized with heart failure, at 30 days, the mortality is about 12%. And if you look at 1 year, it's about 33%. And this is data farther back from 2002, where significant still mortality exists. And at 5 years, 60%. So once you get that 5-year, get that hospitalization, your likelihood of dying is high, especially at 5 years out. So really significant mortality with this disease process. I think sometimes people think heart failure, it's just like diabetes or high blood pressure and can be managed, no problems. But there's a lot of 5-year mortality with this. So this is something you don't see with high blood pressure or diabetes. So it's very, very important to be aggressive with this disease process. Next slide. And as I mentioned before, primary care physicians have the greatest impact on preventing progression. 3/4 of these patients are being managed by their PCPs. Cardiologists are just a small portion of it. So that's why in West Virginia, it's very important for primary care providers to have a role in this. Next slide. And LV ventricular performance is very important as well. These are two different hearts. One on the left has an EF of 55%, and the one on the right has an EF of 30%. And you can look at those patients and you're like, well, the patient on the left has an EF of 55%, well, they're going to do better. Well, that's not necessarily the case. The fact that the heart is thickened, there's not much stroke volume that they have. The one on the left has a 50 mil stroke volume. The one on the right has 75 milliliters of stroke volume. So actually, in terms of work and performance, the heart on the right, although it's dilated, it's compensated and typically gives more stroke volume because it's dilated and has that reduced EF. So that's where kind of it emphasizes those HFpEFs or heart failure with preserved ejection fraction. Those patients are really tough to manage. You diurese them a little bit, their creatinine goes up, they are very symptomatic, they get lightheaded and dizzy very easily with diuresis. So it's a very tough battle, especially with the ones with preserved EF. Next slide. So when we look at ejection fractions, it's considered important in classification of patients with heart failure because of differing demographics, comorbid conditions, prognosis, response to therapies, and because most clinical trials select a patient based on EF. So you have HFrEF, which is heart failure with reduced ejection fraction, and HFpEF, which is heart failure with preserved ejection fraction. But it doesn't really give us information, these reduced EFs or normal EFs, about cardiac output, about diastolic volumes and valvular function. So like on that prior slide, like we were talking about, although the ejection fraction is better, being 55%, it doesn't give as much stroke volume, so they can be very symptomatic. So EF is just a number. We look at a lot of things. We look at left ventricular end diastolic volumes and diastolic dimensions. The LVEDD is what we call it. We look at ejection fraction. There's a lot of different things we look at on how the heart's doing. And next slide. There's even a paper about it, just in reference, misunderstood and overrated, about changing the paradigm and categorizing heart failure. It's really, now they're getting it that just ejection fraction doesn't tell the whole story, and there's a little reference for you. It's a really good paper to read about. Next slide. So another agreed with us two decades later. So we've been talking about this as advanced heart failure doctors, but it's really starting to take shape with this. Next, thanks. So looking at NYH class, we have mild, moderate, and severe. Really, any patient I see with heart failure, I either say they're class 1, 2, 3, or 4, and I say their stage with each clinic visit. So obviously I don't see a lot of class 1. Class 2, they're able to do their normal activities. Class 3, I say, basically they get short of breath with going up a flight of stairs. And class 4, they're short of breath at rest, or a lot of kidney and dysfunction due to cardiac and elevated LFTs or elevated INR. There's a lot of stuff that shows malperfusion is class 4. And this is a spectrum. It can go back and forth based on diuresis. And then not only do I say functional class, but I also use a staging system. But it's very subjective, this system. So we don't have a good way to measure it, and we don't document it very often. So I do think it's very helpful to try to start doing that, because it does show the worse a patient's functional class, the worse they do long term. Next slide. So if you look at walk distance, that's something we look at. Basically, that correlates with functional class. It's something more objective. But the gist of it is, the farther you walk, the better you do, and vice versa. So patients, we do 2 different ways, which is a 60-foot walk test, and it's how long does it take for them to do that. Can they do it in less than or greater than 31 seconds? Or a 6-minute walk test. Can they do it? It's 270 meters is considered better than someone that does 220 meters per se. So the farther you walk, the more likely you're going to live longer. So we use a lot of functional status to drive what our outcomes do. Next slide. So when we evaluate patients for heart failure, we consider 2 parameters. So congestion. Is a patient dry or wet? Do they have crackles? Do they have lower extremity edema? Do they seem volume overloaded? And then perfusion. Is the patient warm or cold? How good are they getting blood flow to the kidneys, their legs, their arms, just the brain? So we look at 2 very important things and kind of categorize them based on that. Next slide. So history of physical exam is very important. Here's an example of patients that had a wedge greater than 22, and what did they find on physical exam? So what really stood out was, for sensitivity, the most important one that I feel is the JVD. So people that had a JVP greater than 12 had a sensitivity of 65 and a specificity of 64. It's not perfect. we use a conjunction with other things. So hepatojugular reflux, we look for. History of pillow orthopnea, are they using more than 2 pillows? That tend to capture more patients. Presence of an S3. But what you don't see here is, what you do see here, which is not that very good at catching heart failure, is edema. Unfortunately, we all together, physicians as a group, use edema way too much to know if someone's in heart failure. So many times, I see it time and time again, they have no lower extremity edema, but they're massively volume overloaded. Edema is not very good at sensitivity, 41%. And specificity is decent, but not perfect. Someone can be having massive proteinuria and have lower extremity edema. They can have venous insufficiency at lower extremity edema, and still have a normal IVC and JVD. So not the best detector. So really for me on exam, the JVD, jugular venous distension, the presence of, crackles is helpful. The presence of an S3, specifically S3, and the JVD and hepatojugular reflux, that's the most relied upon. And other papers have shown that really JVD is the most important one. And that can be difficult to sometimes see on patients. And I think it's a good tool is if you have some kind of pocket ultrasound where you can look at people's IVC. What I do in clinic is I look at their JVD and I say, okay, I think it's this. And then I'll check with ultrasound and say if it is or not. Next slide, please. So expect most of your patients look good while sitting in your exam room, look comfortable when talking with you, tell you that they're tired and that they're on a low sodium diet. That's expectation, but once again, expectations can be different than what is in reality. Next slide. So when you look at hemodynamic parameters, I know this is a very busy slide, but on the top, do they have congestion? If they do, yes, we use more vasodilators and diuretics. Those are patients, they're congested. That's what we tend to do. And then if they have poor perfusion, we manage them differently. We try to poor perfusion, inotropic drugs to bring up cardiac output. Sometimes when they have high blood pressure and poor perfusion, that's where especially vasodilators play a role. Inotropes really can be used, but once you start using inotropic drugs, you're basically saying they're end-stage heart failure and really need to be thought about referral to advanced therapy center. When you use inotropes, you're only putting Band-Aids on the work. So basically, when you're using inotropes, it's a bridge to nowhere. So as soon as you wean them off that inotrope, patients' creatinine goes back up, their cardiac output drops, and so forth. So it becomes really an issue, and so those are definitely triggers to referral. Next slide. So when you look at patients, wedge predicts subsequent mortality. This was done in 1994, and what you see is people with higher wedges on right heart catheterization. So wedge is basically measuring the left-sided pressures of the heart. We go into the Swan-Ganz catheter through the neck and float a catheter, excuse me, into their pulmonary artery, and then get into a wedge position, which indirectly measures left atrial pressure. So the higher the pressure on the left side of the heart, the worse they do. And that's what they saw in this study. However, cardiac output, there is no difference. So people with a cardiac index less than 2.6 and lower limit of normal is, kind of 2 in my book. 2.5 is what they really reference here. Patients with a normal cardiac output, when you reference them, no difference between that with lower cardiac outputs. But the cutoff of 2.6 is pretty high, so that's one of the reasons why you don't see a difference. But once again, going after the wedge, diuresis and afterload reduction is key. Next slide. So invasive evaluation. So this is a class 1 recommendation. So when do we swan people? When do we put a pulmonary catheter? It helps guide therapy in patients who have respiratory distress or clinical evidence of impaired perfusion. So that's really important. So people that are really short of breath, you're struggling with them managing their volume status. You need inotropes or not. Those are ones that are very helpful for that. or in whom the adequacy or excess of intracardiac film pressure cannot be determined from clinical assessment. So you're not sure if they're wet or dry, their creatinine's going up. That's a really great time to use a Swan-Ganz catheter to directly measure the pressures in the heart. Next slide. So beta blocker story. So back in the old days, beta blockers were contraindicated in patients with heart failure because they felt, oh my gosh, someone just had a heart attack. You're going to use a beta blocker. You're going to blunt their response and hurt them. But actually, the opposite was true. Next slide. And this is about the beta blocker story. So next slide. So the effects of beta blockade on mortality, really the only ones that are approved that decrease mortality in heart failure are metoprolol succinate, not metoprolol tartrate, but metoprolol succinate, which is toprolol XL, carvedilol, also known as Coreg, or bisoprolol. Bisoprolol is used much more in Europe, but in the U.S. carvedilol program, decreased mortality. CBIS, decreased merit, which is metoprolol, and carnipricus, it's hard to say, but decrease hospitalizations and mortality with those. So beta blockers, time and time again, show decreased mortality, and one of the goal-directed therapies we use. I will tell you, though, when people come in acute heart failure, new diagnosis, I tend to use afterload reduction first because that makes them feel better. That brings down their blood pressure. And then I put on the beta blocker because there's a lot more side effects that you see with beta blockers. But I always get those patients on it. And when I treat these patients, I tend to use heavy afterload reduction. So a lot of ACE inhibitors, Entresto, use a lot of that heavy, and then I sneak in the beta blocker. But I never go heavy on the beta blocker up front. Next slide. And with the trials, Merit was with metoprolol XL, CBIS was bisoprolol, and lastly, at Coreg trials, all showing decreased mortality with the agents and significant decreases with it. Relative risk decreases of 35% on average. Next slide. So beta blockers in acute heart failure, sometimes they can intensify and exaggerate heart failure. I don't use beta blockers when they're unstable heart failure, they're hypotensive, they're severely volume overloaded. Obviously, if they're on dobutamine or inotropic agents, or if they're bradycardic, heart block, or really bad bronchospastic disorder, I tend not to use them. But the bronchospastic disorder is very rare, so the other ones are very true. So I'm very careful with the beta blockers. Next slide. And when you look at beta blockers and heart failure exacerbation, it's very important. I see time and time again, what happens is you stop the beta blocker on the hospitalization and then never gets restarted, and then you're hurting them long term. So really a good rule of thumb is someone comes in with bread and butter heart failure. If you're going to do something, cut the dose like in half. So that always reminds people to restart the beta blocker. I mean, not restart, but increase it back up. So it's always on board. And abrupt discontinuation patient with symptomatic exacerbation should be avoided unless the situation is life-threatening. So low cardiac output, cardiogenic shock, severe hypotension, you're worried about renal failure from low output, those are the times you hold beta blockade. Next slide. So if you compare Coreg and metoprolol on clinical outcomes, this was the COMET trial. Both are, have been used. Metoprolol tartrate was the one that they used against Coreg, and that's why metoprolol tartrate was shown to be inferior, but the dosing regimens were not fair, to be honest. So that's why metoprolol tartrate didn't get approved, and that's why it's a metoprolol succinate we use in heart failure. So carvedilol, metoprolol succinate, and bisoprolol. Next slide. So when we look at heart failure, the things that we look on, this is the Frank Starling curves looking at preload and afterload. As you can see, when we decrease preload, the red line represents patients with heart failure. The ones on the white line represents normal patients without heart failure. And we can make big differences on preload with patients with normal heart on cardiac output. However, we cannot really do a good job increasing cardiac output when we affect preload. So what we really focus is on we focus on is afterload reduction. That's the hallmark. That's the ACE inhibitors, ARBs, hydralazine, and so forth. So as you can see in the slide on the right, patients that have decreased contractility are very afterload sensitive. So as you can see by the bar graph, not the bar graph, but the line graph, basically the farther down you go on the curve, you get worse cardiac output, so it goes downward. And as the afterload gets reduced, the line goes to the left, cardiac output goes up. So that's why we use a lot of nitroprusside in the ICU. We use a lot of hydralazine. We use a lot of ACE inhibitors, ARBs, and Entresto in these patient populations. So the biggest bang for the buck to improve cardiac output and improve how they're feeling is really decreasing afterload. Next slide. So in guidelines, all patients with reduced EF should receive ACE inhibitors, whether or not they're symptomatic, unless they have a contraindication. And then doses should be titrated, used in trials. So time and time again, I see patients come to me, their blood pressure is 140, they're on co-reg 3.125, lisinopril 2.5 daily, and aldactone 12.5. So really, every time I see them in clinic, I try to figure out what drug can I try to increase. A blood pressure of 100 is not a reason not to go up on a medication. They truly have to be symptomatic, blood pressure less than 90, rising creatinine. There's got to be good reason not to try and challenge a patient. Even if their blood pressure is 95, 100, I'll still try to do it because long term, I know the higher I can go up, the better I do. European Society guidelines have some good, really, criteria of what gold doses are. For example, enalapril is about 10 milligrams twice a day. So they have some really good targets for you guys to try. ARBs can be used in patients tolerant to ACE, like cough. We really stay away now from, there's a charm added trial that showed ARB and ACE, but we don't do that anymore because it really doesn't affect mortality. And people have renal insufficiency, I still use ACEs and ARBs, but if the nephrologist is concerned or I'm concerned, then I use hydralazine and Isordil in those patients, or if they have hyperkalemia. But even with hyperkalemia now, there's newer drugs out to drop potassium, so you can use ACEs and ARBs. Veltazza is out there, so there's other stuff we can do now in this patient population. Just because they have a creatinine 2 doesn't mean you can't use ACEs and ARBs. Especially patients that are diabetic with proteinuria, I tend to still use a lot of ACEs and ARBs, but I think it's really important. They get a benefit for their diabetes and for their heart failure. If their creatinine goes up to 2.2, 2.3, I keep on pushing through. I just keep an eye on those things and see how they're doing. Obviously, when they have elevated creatinine, I do this in concert with their nephrologist so they feel comfortable with the plan. Next slide. So if you look at CHF mortality, depends on the level of neurohormonal blockade. Patients on beta blocker plus ACE, every in about 23 months, so about 6% per year. If you look at patients not on beta blocker ACE, about 15 to 16% per year. So you get significant reductions in mortality and sudden cardiac death with this patient population. So really important not to just do ACEs or just do beta blockers, but do beta blockers, ACE, your aldosterone antagonist like spironolactone. Just like in chemotherapy or HIV therapies, we do a lot of multi-drug combination. That should apply to his heart failure as well. Just don't do monotherapy in this patient population. Next slide. So if you look at the AHAP trial, the primary endpoint, all individual components of the primary composite endpoint were significantly improved with Isordil and hydralazine therapy, namely death, first hospitalization for heart failure, change in quality of life. So really, Isordil, hydralazine, when ACE inhibitors can't be used, are very helpful in this patient population. And in this study, in African American population on max therapy, they added Isordil and hydralazine, and they had improved mortality compared to the placebo arm. The placebo arm was the ones without Isordil and hydralazine. So basically, with African American populations, they still have to be maxed out on their beta blocker, ACE inhibitors, and aldactone. If you can, try to add Isordil and hydralazine in that patient population. Shows decreased hospitalizations and improved mortality. Next slide. So then we had the paradigm heart failure trial, big game changer in my opinion. I used a significant amount of Tresto in this patient population. They looked at patients with EFs less than 40% and New York Heart Association 2, 3, and 4. And they looked at CV death and heart failure hospitalization. They had a run-in period with enalapril, 10 BID. So really goal-directed therapies. And then they looked at Entresto and got to treatment dose is tolerated of 97/103 and got compared to enalapril 10 milligrams BID. So really robust dosing in this trial. And this is in patients with chronic heart failure. There was a trial that just came out with acute heart failure, and they showed benefit as well. So even new drops in EF that I don't think is immediately obviously reversible. If someone has coronary disease and they get revascularized, I tend not to use Entresto. Or if someone has tachy-induced cardiomyopathy or hypothyroid-induced cardiomyopathy, I tend to put them on standard therapy first and then add Entresto if that fails that regimen. Next slide. So you can see by the, and then there's a 36-hour washout due to angioedema risk. So that's really important. So patients on ACE inhibitors, we always keep it off for 36 hours and then introduce Entresto. There was 2 different arms based on blood pressure and creatinine. ACE and ARB, 24, 26 for the naive patients, and then the moderate doses, 49, 51. And they titrate every 2 to 4 weeks to get a goal dose, 97/103. And however, in the study, their BNP increases due to the Entresto, so it's not a very reliable marker. What you really need to use is pro-BNP in these patients. So I will tell you, though, when patients are on stable doses, I'll check a BNP, and then depending on what the trend does, helps out with how they're doing. When BNP is dropping on max dose therapies, then I know they're heading in the right direction. Next slide. And as you can see in the study, the primary endpoint, enalapril versus Entresto, which was LCZ 696, the mortality was lower in the Entresto arm. You had decreased death from CV causes, decreased hospitalizations for heart failure, and decreased death from any cause. So really robust study, really. And what they did was it was powered significantly. A lot of patients were enrolled. So really was a big game changer. From a heart failure standpoint, almost every patient I have, I usually try to switch them over to Entresto, even if they're asymptomatic, if they still have a reduced EF. Obviously, if they have a normal EF, I keep them on whatever regimen they're on. Next slide. And the number needed to treat for the primary point was 21. And then the numbers needed to treat for prevention of CV mortality was 32. So relatively smaller numbers. Usually in other studies, those numbers are much higher. So it's a very robust study in terms of improvement. Next slide. So at this point here, the clinical course of heart, I'm going to stop right here and move over to a case presentation.